So we've been hearing lots this about driving pressure. What exactly the driving pressure is? How does it play? Does it really help us?
Yeah, I think it could be helpful to give the short answer, but we also have to realize that the driving pressure is what I sometimes say a global parameter. So it's looking at the whole lung system, and it could be that the lung tissue is affected heterogeneously, meaning that you have areas that are more affected. Exactly. And then the driving pressure of the whole system might help us, might tell us something, but I'm not sure how it is in certain parts of the lung. That's, I think, one of the problems that we have is the driving pressure, but it also applies to all these other factors that we are using or trying to improve. The heterogeneity might be the big problem in setting the ventilator right.
So we hearing this lot about the driving pressure, and initially as Amato went through the 9 RCTs, he really initially in the first phase he started as a predictor of a mortality, and then when he analyzed it, he realized, yes, if we have a good driving pressure, when the what we calculate pad to pressure minus P was less than 15 or less than 14, then they had the better outcomes. So is there a way where we can manage this and play around this?
It's part of the story, I think. We have to realize with the driving pressure that it's not only by the way we apply mechanical ventilation, but also how sick the lungs are. And we all understand if you have a very sick lung, the driving pressure would be higher to manage. And then your outcome could be worse because you are so sick and not because of that.
So this is how he started with his
Exactly. The big question is, can we influence the driving pressure? There are 2 ways maybe. You can try to recruit lung tissue, but we all know that recruitment is not beneficial in all patients using PEEP or recruitment maneuvers. The other way is reducing tidal volume size. So it's an interplay between different factors. Indeed, tidal volume should be low, but sufficiently low. Respiratory rate should be set adequately, and the resulting driving pressure is affected by both. And the 3, probably with also a lot of factors like flow, is determining the amount of mechanical power or the intensity of ventilation. But studies are lacking in this respect, and we need to design better studies.
And they are looking into this. Yeah. Or do we look in how do we initiate and have the low driving pressure? As you said, if the lungs are very bad, it's not always possible to achieve those targets as well. So how do we start it? And maybe I'm aware of one of the study we are looking at the driving pressure, the latent position as well, which will be semi-published.
Correct. Yeah. I think to put some extra emphasis on this, I think setting all these parameters is quite difficult because the one setting will change the other setting or will have an effect on the other setting. And I think here it could be a case for artificial intelligence or automated modes of ventilation that do this automatically for us, so that we as clinicians, nurses, doctors at the bedside have an easier job in setting these different factors or different settings in the correct way.